welcome. Thank you for joining us this morning. We appreciate the opportunity to be with you and to talk about our discussion of how COVID has impacted the patient experience, our healthcare system, and patient innovation. My name is Tom Hawk. I'm a partner at King & Spalding on our healthcare team. I focus my practice on healthcare mergers, acquisitions, and other transactions. I'm based in our Atlanta office. My co-presenter, or our presenter, is John Bardis. John, I'll let you introduce yourself.
Thanks, Tom. Welcome, everybody. It's great to be with you this morning. I want to thank Mark and the whole Health Connect South team for putting this together. It's not easy to do, particularly in these times. I have served in different roles in healthcare, primarily in the private sector throughout my career. I served as president of a company by the name of Kinetic Concepts, especially wound company. And then after that, served as president and CEO of a subacute rehabilitation and long-term care business by the name of Theratex. And then in 1999, founded a company by the name of Med Assets, which was the largest supply chain and group purchasing organization in the United States. We also managed about $500 billion a year worth of primarily hospital claims, and we did clinical consulting, interfacing with clinicians, largely around cost and payment models. And presently today, I serve as Chief Executive Officer of ShareMD. I served in this administration as the Assistant Secretary of Administration for Health and Human Services. So I've been around healthcare a bit, and glad to be with you this morning.
We appreciate you joining us, John, especially since John is on the West Coast, 3 hours early, bright and early out there. Well, to frame our discussion, let's go back to February 2020 BC, before COVID. The U.S. was already on the cusp of significant demographic and fiscal challenges as the baby boomers age into Medicare age at greater rates. How did the healthcare sector at that time fit into the broader U.S. economy?
Yeah, thank you, Tom. Well, first of all, many people who follow healthcare sort of have a sense for this. Most outside of healthcare don't. But U.S. healthcare today represents approximately pre-COVID about 20% of what was a $21 trillion economy. So the American economy is the largest economy in the world, by far the most productive on a per capita basis of the large economies. The second largest economy is China. Third is Japan, and fourth is Germany. About 2 years ago, America passed, with just its healthcare expenditures, the entire GDP of Germany. In other words, U.S. healthcare is the fourth largest economy in the world by itself. It is approaching $4 trillion in gross expenditures, and that number will go at the end of 2025 to $5.995 trillion, making it a $6 trillion part of the economy. I'm unaware of anything, just on that note, Tom, that has ever grown $2 trillion in 5 years in the economy. But U.S. healthcare will do that. You mentioned a minute ago the mix shift, baby boomers. Today, we will see between right now and 2025 approximately 39.5 million new transfer payment beneficiaries. What I mean by that is these are people who will leave private insurance and either become a Medicare beneficiary, a Medicaid beneficiary, which is the state underprivileged, and then the uninsured rank. So Medicare will grow by about 19.8 million beneficiaries. Today it's moving at a clip with the boomers at about 10,000 a day. Medicaid will grow about 10.2, and the uninsured will grow by about 9. So all those folks will need health care, and typically speaking, those transfer payment beneficiary programs pay substantially less than the private sector. And so when negotiations occur, the cost for those utilization increases tend to fall onto the private sector, and more specifically American businesses and their workers.
You highlight a good point about the cost shift that goes on, and I want to come back to that in a second. But first, I wanted to focus on how the COVID pandemic, together with the government mandated suspension of elective procedures, highlighted the weakness in how the U.S. funds its healthcare system, particularly the fee-for-service model. Was when the elective procedures went away, the fee-for-service model dried up, and hospitals and other providers quickly found themselves in a cash crunch. What is the path forward from here?
Well, that's a great question, Tom, and I'm really thankful that you pointed that out. The American healthcare system was largely founded, as we know it today, on a fee-for-service model, which is by and large you get paid only when you do something to someone. So the health delivery system, particularly the IDNs, the great systems that we have in Atlanta, like Emory, and public hospitals like Grady, right? They are largely paid when someone comes in and they have to do something to them. Whereas on the other hand, if you look at Kaiser, and they're very strong and have a lot of depth on the West Coast, Hawaii, and Colorado, they are a value-based model. They can do that in large part because they're the payer, they're the provider. They are also have all of the physical facilities by and large in their marketplaces. And so their model actually financially does not incent the delivery of specific cost-based care, but really more management of the life of the member. And so to your point, because of that, and today approximately 80% of all that the hospitals do, and in many markets it's way more than that, is based on fee-for-service. So because electives were stopped, this really put a cash crunch on American hospitals. Now, the Paycheck Protection Program and Congress putting money out into the economy sort of staved some of the problem associated with that off. But nonetheless, the hospitals, to your point, remain in a recovery mode, focused on this fee-for-service. And so you asked another question, and what I would share is, value-based care works. I think the most successful part of Medicare right now is Medicare Advantage. And Medicare Advantage actually incents the provider to engage with populations of people. And in doing so, they do have the resources, the physicians, the facilities, the programs to manage the health of patients.
It seems like such a monumental effort to move from our current fee-for-service system to value-based. I mean, what are a couple of the steps to get us there?
Well, it's a really tough one because there are so many parts of the system that are presently well incented to focus on the fee-for-service model. So we have to remember that the model that we now are working with causes everybody involved. This includes manufacturers of product, it includes health systems, to learn to effectively amalgamate their costs. And in the case of health systems, they've successfully aggregated assets, right? And just by way of a bit of backdrop, health delivery in this country was ultimately heavily influenced by consolidation on both sides. And we saw insurance consolidations in the 80s and 90s. That led to pricing power. The response to that pricing power was that hospital systems and IDNs began to form and consolidate. And taking that one step further, health systems then successfully acquired approximately 53% of the physician practices in the United States, which then gave real negotiating power. And so what that has done, in my view, is it's exacerbated the cost challenge. I can give you an example. A very large West Coast teaching institution that we would know well last year, based on the cost structure that they have, and bear in mind that in order to have a reason to negotiate a higher rate with private insurance, the justification is typically the costs have gone up. So we've incented that actually. So demonstrating that in a payer negotiation has become a key portion of pricing. Last year, this teaching institution had approximately 64% of their unit consumption within this large hospital system, Medicare and Medicaid. And on that book of business, they lost, according to the way that they account for it, approximately $750 million on that book of business. In total, the system last year earned a positive income of $250 million. And that came from approximately 34% of their unit consumption. So that unit consumption at 34% was the private sector. But in comparison, the private sector was upcharged over cost more than $1 billion to cover that loss. This has been part of a primary driving force raising premiums and co-pays for the average worker and their family. And that's what businesses have had to do, because by and large earnings at the corporate level haven't grown as fast as healthcare costs. And that will, I believe, be in particular true going forward because of the bolus that you and I spoke of a moment ago, Tom.
Exactly. I mean, it is, as you describe, effectively an implicit tax on businesses in the U.S. that offer commercial health insurance, which are most large ones are mandated to now. Effectively, the private health insurance has to cover the losses of government patients. How do we address that in particular in the shift to value-based care? And maybe the fact that some of these systems have consolidated, or the hospital systems have consolidated, helps somewhat, in that it at least provides some unity in a system to implement value-based care.
Yeah, no, you're right. And also too, Tom, to your point, I mean, in some respects, COVID has also opened the door for thinking about these things differently. There's no doubt in my mind that these health delivery systems have the capability of redesigning the way care is managed, whether it's telehealth, different kinds of telemonitoring, or taking risk for broader populations. But they don't typically, as individual systems, get to make those decisions, right? The payment decisions historically in America have been led by the federal government. So very rarely do you see innovative approaches that on payment reform that start in the private sector. So CMMI at Medicare is sort of the experimental agency within the department that takes on these kinds of things. I really do believe, though, that the business community would be wise to organize around this, and not in a way that is designed to threaten the current system, but rather encourage it to really rethink how we manage the life and risk of workers. Because there's a lot of discussion today around inequality, but in the end, economic equality and inequality, the line is blurred between what you make and what you keep. And the what you keep part is a pretty big deal. And that's the part that's been most under assault. It's also one of the reasons, in my view, why the Georgia economy, and particularly Atlanta, has done so well. And what I mean by that is we haven't necessarily addressed the healthcare cost problem better than anyone. But what I would say is we have other advantages that are terrific, right? We have low cost housing. We have, generally speaking, very low cost of living compared to places like California, New York, other locations. And that's really helped us economically. But until we begin to address the real risk to a working population of the incoming utilization increases from Medicare and Medicaid that we now just talked about, I think we've really put our middle class and working families at financial risk going forward. And I suspect over these next several years, these kinds of alternative models are going to have to be addressed.
Right. I mean, I agree. And to your point, COVID provides a great incentive, not a great, but provides an incentive and a stressing point to drive change in the system. What role will price and quality transparency, which has received some focus in the current administration, have in this transition?
That's a good question. Yeah, Tom, the one thing I wanted to get done when I came to Washington, and I asked for permission to do this, and it was agreed, was to focus on price transparency, because at the end of the day, I really do believe that the American consumer and American businesses are incredibly wise users of data to make better purchase decisions. And we've seen how American consumers have led dramatic shifts in cost on virtually everything, from telephones to smartphones to computers to you name it. The amount of efficiency that American supply and demand transparency has created has forced us to move fast in other markets. So I did ask both the Secretary and the President to consider a transparency rule that basically said, since we as taxpayers are the underwriters of federal payment, we are also the underwriters as workers of private payment, that all of those payments really need to be a matter of public record. And it's true in every other market that we know which functions correctly. And that is, consumers and businesses and industrial B2B buyers have access to real pricing that cause them to make supply and demand decisions. And the good news is that we wrote a lot of that basic work, and the President put it into action with an EO last November of 2019. So I'm very hopeful about this, because I know some of my dear friends in the IDN side of the house won't love this, but in the end, I do think it will help them redeploy capital and resources in a way that serves their markets. This won't solve everything, right? I see we have a question about rural hospitals, and I think we should, address that. But I do believe that if the consumer is in charge, and this is happening daily in America now, just last year alone, our model, Tom, which is a catchment referral network model, right? The way that we access a physician, particularly if we need a specialist, is typically from our primary care doc, who makes a decision about who to refer us to within network. We don't really get to choose, by and large, who that is, or historically that's been so. Here's an interesting thing, and I believe it's been led by the digital revolution. Last year, the full acceptance of referrals from primary care to specialty throughout the United States fell by 40%. Patients actually chose, in those cases, to seek a second opinion from information that they gathered on their own. This starts ultimately with reputation management, but in the long run, in my view, it goes to real life clinical data that allows a potential patient to look and determine which particular physician or caregiver or institution does this well, the service that they need rather. And you'll note that even organizations like the Mayo Clinic, who are some of the best brand names of any in the world, not just in healthcare, but very well known, their bounce rates on their website are something like 85%, because the website is focused on the health delivery system and not, generally speaking, what the patient is focused on, which is finding a physician, a one-on-one relationship.
I guess the challenge historically, price transparency is one thing that's it's not completely objective, but it's a fairly objective measure. The challenge the provider community has had with quality transparency is what kind of indicators do you use on the hospital side, but then also, to your point, on the physician side, and how do consumers know what's important and what's not important?
Yes, it's a great question. So, I believe that we have approximately 1.3 million physicians in the United States. And to my thinking, they're, as a large group, the smartest large group of people we have in the United States. I know there are nuclear physicists out there, but I just don't know how many. There are many smart doctors. And when we give doctors the leeway to actually do the work to design critical pathing, not just for clinical pathing, but critical pathing for patients to access care, I find that we get good results. Unfortunately, what we've done with the implementation of electronic medical records is we've burdened these incredible athletes, these incredible talents with a tremendous administrative risk. I not very long ago was on a neuro ICU unit, and I watched the top neurosurgeon in that health system spend 15 minutes of rounding seeing his patients, and then observed him spending the next 45 minutes of this one available hour for rounding that he had adjusting electronic medical records, inputting data. And to me, that is exactly what we don't want or need. What we really need is these physicians to, one, focus on the best clinical outcomes for their patients, which they certainly attempt to do, but we need their minds, because if you really ask them and spend time with them, I have found that they're outstanding engineers in making recommendations as to how things can be done better and more efficiently. And this includes communication. I recently sat down with a very well-known surgeon who also does a lot of reconstructive surgery. But what he does is he takes a virtual nurse assistant for him, who's actually in the Philippines, who does all of his transcribing over a secure link on his iPhone, right? So he leaves the nurse with the patient as he goes on to another patient. And the bottom line to me is, Tom, our forward future really has to include an acceleration of clinical economic energy, taking advantage of the productivity level capacity of our current delivery system. That's how we're going to be able to absorb this enormous bolus of Medicare and Medicaid patients coming, as well as the uninsured, while helping the next generation transition. But that means we have to put tech and smart processing into play. And I think those entrepreneurs who move in that direction are going to be very successful, because I think the economics press us into that position.
I couldn't agree more, particularly with respect to the need to allow physicians and other clinicians to drive and design the innovations that will ultimately result in the best adoption rate by those clinicians. Let's turn to that question that was submitted by one of our viewers joining us today, and it relates to the tension between value-based models, which rely on a pretty consolidated health system, which exists in some urban areas, with how care is delivered in the rural setting, when there will be less of a full continuum, of care available so that a hospital, for instance, could take advantage of a value-based system, or it'd be more complicated for them to do it, rather. How do you see the rural hospitals and other providers fitting into that?
Yeah, it's a great question. I think America has to remember its roots in this way. The rural-based delivery system is essential to ensuring that agriculture works. As it turns out, right, if you go back to 1908, the two largest companies in the United States were both meatpacking companies, Armour and Swift. This was as a result of the migration, the first major migration ever of large populations from the farm to cities. This country has made, over time, revolutionary improvements in food productivity, and it is the rural communities that get that done, whether they're in Iowa or southern or middle Georgia or Minnesota or Wisconsin. And it's a central theme to the long-term success of our country's ability to move forward. So I think, it's my opinion, that rural hospitals need all the support that we can give them. I don't buy into they just need to go away. They do need to transition. So where appropriate, what might used to have been a hospital might turn into a clinic with an appropriate set of technological tools that allow immediate access to ER physicians, diagnostic tools, those kinds of things. These are yet examples of opportunities where potentially technology could assist rural communities. But it is essential that America maintain its rural hospitals or rural care, moreover, in a way that is consistent with being able to treat everyone in those communities, because those communities pull way more than their weight when it comes to the impact that they have on our society and the American economy and culture, just on food production alone.
What role will telehealth and providers like Teledoc, for instance, play in that?
Yeah, I mean, great question. So, I mean, I think COVID really opened the door here, didn't it? I mean, it accelerated the whole question around telehealth and Teledoc and others. American Well, I think, is going public now. So I think they're clearly proving their worth. I think the challenge, Tom, the bigger challenge will end up being how much of the pie should they get? Right now, it's not very much. It looks good on paper, right? But in reality, the vast majority of the real capital remains deployed toward inpatient and outpatient ambulatory procedures, largely IDN and office-based, brick and mortar. So we've got many trillions of dollars now continuing to really be focused on those institutional brick and mortar models. The reimbursement levels and Medicare has definitely moved quickly here, but just the level of payment remains relatively low compared to the incentives that we presently see and have seen historically to have an inpatient or ambulatory event. Now, another example of some of the movement from payers is that payers are in many markets now saying to hospitals, look, this is whether you put an ASC inside your hospital or whether you put an ASC across the street, we're not differentiating that payment. That wasn't always true. So we're seeing payers react much more aggressively, and I think they will continue to react much more aggressively. Whether they make the broader transition to a deeper payment, a more robust payment for both monitoring and diagnosis for a telemedicine or an electronic model is yet to be seen. But, we tend to follow the money. And then also, to be fair, to protect these community-based assets, particularly in major cities, hospitals have been very effective on Capitol Hill. I mean, I'm not sure anyone is more powerful in getting the attention of Congress than they are.
I agree with that. And I do think it is true that payment for monitoring chronic diseases and monitoring patient populations in general is going to be key to a move to any value-based care model. I mean, that's going to be necessary to take the step away from the fee for service. You've got to come into my office for me to get paid X dollars, or else it won't work.
Yeah.
I wanted to change gears here a bit, thinking more sort of futuristic ahead down the line. What role do you think genomics and gene therapy will play in the future of our healthcare and healthcare delivery system?
Great question. Thank you for asking it. This country, and we tend to forget this, right? Because we're people and we're busy and we want things done better today. But just to put this in perspective, the average life expectancy for a white male in the United States in 1900 was approximately 43, 44. The average African-American male was 31. And by the way, this reality existed throughout human history, right? That we've had short life expectancies because of disease. We've had enormous infant and child mortality rates. My own mother, who passed a year ago, was the last born of 11 Russian immigrant children, 3 of whom died in childhood. Very different and difficult times and things that people were generally used to. So in the last 100 years, we've changed so many things for the positive. Penicillin came into being in 1933. Public health began to be really effective in teaching things like hand washing, and we eradicated smallpox and yellow fever and so many other diseases. So public health has worked and the health system has worked. And therefore, from that, we've become the most productive nation on the planet. hard to do that with a population that's not growing or dying young. And I think the next generation is just around the corner. Over time, I got to know Dr. Francis Collins at the NIH. He's Tony Fauci's direct boss. Tony and he, along with that whole staff, are just simply amazing, remarkable people. And Dr. Collins wrote a book called The Language of God, which I carry with me all the time. Dr. Collins in 1998 was responsible for unveiling and leading the entire 4 billion sequence human genome. And we now know what the human genome is, what it looks like. And we also know, for example, certain types of breast cancers, which genes have been mutated. And so I believe, Tom, that maybe not in my lifetime, but I think my children's lifetime, and certainly our grandchildren's lifetime, that we will see a dramatic shift in how genomics plays a role in providing medicines that alter what historically are death sentences coming from certain types of diseases. And I also think that that is very possible for the autoimmunes that are out there. I think there's a real chance that they're going to be gone. So the next generation of medicines and science are, to me, incredibly exciting in promoting improved life expectancies, and better set of choices for both working people, poor people, and those with resources. So, I'm very bullish on the future. It doesn't mean that the road won't be rocky from time to time getting there.
Well, I like the hopeful and visionary response, and we're looking forward to that. We did have a couple questions in the queue that I wanted to turn to, one of which I think dovetails well with respect to our earlier discussion about value-based care, and it is, what role can clinicians other than physicians play in transitioning to value-based care? I guess this would be physician's assistants, nurse practitioners, et cetera.
Yeah, I think, depending upon where those clinicians are employed, the health systems, the IDNs specifically, have the ability to move away from an RVU-driven payment system, which is used today for physicians, and provide productivity and health management-related incentives on value-based care. And by the way, we see that, it's been proven with Medicare Advantage. Medicare Advantage really works. It is a challenge, right? Because there's an oath that says we're going to treat everybody to the best of our ability, and I think the health systems really attempt to do that. But how do you produce incentives in transition? So we know that it's working, that approximately 30% of Medicare today is Medicare Advantage. It works beautifully. But yet then there's that remaining 70% of Medicare. We probably didn't move this fast enough that you can only get paid if you do a procedure. And it seems as if you do that procedure on an inpatient basis, you got to then charge somebody else a lot more money to make up for the cost you would have preferred. So we still have those diverging incentives. But I believe from telemedicine to value-based incentives, that everyone from nurse practitioners to nurses to therapists, all the way to our highest level physicians, can be incented either through salary and bonuses associated with how we manage those populations and actually measure outcomes and results. I think the trick is, how do you do that while still having one foot in the past?
I agree with that, and I also think that the nurses, nurse practitioners, physician's assistants are going to play a key role moving forward as the Medicare population expands with the baby boomers, and we see primary care, the greater shortage of primary care doctors continue to be exacerbated. These types of professionals can step in to fill the gap where needed. We have another question in the queue about freestanding urgent care systems and telehealth and freestanding urgent care systems, and how they fit in to the overall healthcare delivery system. Are they siloed, or are they linked in to a broader system?
Well, yeah, I mean, that's a great question. I think that, we've learned that many of the ER visits that are happening today are a reentry point that create extraordinary and in some cases unnecessary costs. We had seen this in a particular hospital system in Chicago that we were working with. We were asked to come in and do a cost analysis and reduction. And we found that there were 4 nursing homes in the market that hospital served, whose normal route of processing anytime a patient fell ill was to process them through that ER. My view is that telehealth and other reimbursed telemedicine type programs will eliminate many of those cases that up to this point in time only had the ER as an access point for medical care delivery. So I think urgent care centers are critical. And I also think that if I were running an urgent care center or any health system today, I would not rely solely on the catchment model, which is sort of a wait and catch, right? We wait for someone to refer to us. We wait for someone to show up, but we do very little to actually use digital platforms to empower individual consumers to find us, come to us, be proactive. Now, every other business model in the United States today that is of substance has made that transition, whether it's Amazon or Google or Facebook. Look, whether we love this or don't like it, the reality of it is those digital platforms know everything about you. It may not be a personality that knows everything about you, but that computer knows you. And every time you do something, the machine learning aspect of those systems finds out to a much greater level of detail who you are and then messages you. And that's not 100% bad. I'm not in favor of some of it, but my point there being is there are ways and there are technologies today that allow us to reach consumers as patients more efficiently, also provide channels for them as a result of building relationships through the digital platforms where they can make better decisions or access better choices as it relates to healthcare. And I do think this is particularly valuable and has great potential in rural and for urban communities. So this isn't just for everybody every day who thinks that they want to deploy their healthcare dollars more efficiently. I think we're learning lessons from the whole psychographic mapping, the whole digital marketplace consumer identification model. And what we're seeing, Tom, is that the young people are buying into this and they're moving much more rapidly in their change of healthcare decisions using digital.
I totally agree that the youth are driving the move to technology. I guess one limitation of that that's been pointed out in the questions is if you look at people who are 80 plus in the Medicare population, their adoption of technology may not be at great a rate. And how do we help them take advantage of what technology may offer in terms of quality, transparency, finding providers, et cetera?
Yeah, well, great question. If I were king for a moment, right, one of the things I think would be worth exploring, and this question was raised about long-term care and value-based medicine. And you're right, the long-term care environment does not have meaningful incentives in a value-based care model, right? You bring somebody into an LTAC or a nursing home, and it's a fee-for-service model, and you're incented to keep them there. And of course, in many cases, that's really the only choice because the patient needs so much more attention, and it's a straight up, what will Medicare pay us? What will Medicaid pay us? And what can we hire people and build buildings within that cost structure to support it? So I don't think we have the best answers for long-term care, although what I would say on that is I do think telemedicine is a factor there. I know that if my wife were ready for more assisted care, my first choice would be to use as much telemedicine. By the way, my wife is healthy. I wasn't drawing parallel, but if I needed to do that, right, I would use telemedicine and intermittent caregiving because I want her to be in her home. I'm just not a long-term big believer that the best choice is a Medicaid or Medicare long-term care facility. I think we've got to pay families if necessary, pay caregivers to come to the home and do what we can in the home. Because if you look at the numbers, it makes it hard to believe we'll have enough facility for that. But going forward, right, the ability to monitor, the ability to measure, the ability to communicate with patients on a telemedicine basis is becoming better. And I think we need to throw as much as practical as possible, frankly, at those models. How do we do that while we continue to support meaningful brick and mortar in our metropolitan and rural communities? Those are policy challenges that are not simple, but I think have to be considered.
Thank you, John. I think we have run through our time. This is a very helpful discussion. I appreciate you joining us, and thank you to the Health Connect South team for putting this platform together and pivoting to a virtual platform as that became necessary. Appreciate you joining us all today.
Thank you. And Tom, thank you. It's great to be with you all out there, and I wish you all the best. We'll look forward to the next time.
Thanks.